Hello, my name is Dr. Jason. I'm an evidence-based chiropractor from Toronto. So today I'm going to do another home workout and also talk about low back pain. Because I don't want to misquote any stats, so I'm going to bring some resources to talk about this topic. So the source I'm using is from the International Association for the Study of Pain. Now, low back pain has been a leading cause of years lived with disability since 1990 and remains a significant global public health concern. Now, the point prevalence of low back pain, which means that at any given moment in time, how many people or what percentage of the whole population is suffering from low back pain. And that statistic is estimated at about 7.5% of the entire global population, which means out of the a billion people that we have in this world, there are about 500 million people, approaching 600 million people that's suffering from low back pain at any given time in the world. So I think that is a lot of people, more than the population in the United States, more than the population of Canada combined, that's suffering from low back pain at any given time in the world. Now, low back pain is not usually associated with a specific identifiable pathoanatomical cause, which means that usually there isn't any one structure or even multiple structures that's contributing to your low back pain. It could be a combination of those or none at all. So, a lot of times like chiropractors, we say, oh yeah, the cause of your low back pain is your muscles, like the multifidus, or it's from your facet joint. That is actually not true. And about 85 to 95% of all types of low back pain that we see as primary care providers do not have those specific identifiable pathoanatomical origin of their pain. Obviously, with certain specific identifiable cause, about 4% is due to vertebral fractures, about 5% is inflammatory spondyloarthropathies, and about 0.7% are due to malignancy, and then 0.01% are due to infection. Oh, by the way, malignancy means cancer. So you can see the chance of you having back pain that's due to cancer, infection, some specific type of spondyloarthropathy, and due to fractures is actually very, very low. So again, 85 to 90% of all types of low back pain are non-specific back pain. In addition, low back pain does not always lead to disability. For those who suffer from chronic low back pain, 1 in 3 people perhaps live with disability. And now the way we manage low back pain is through what we call a biopsychosocial framework or model. And that's how I explain pain and low back pain to patients. Bio means our biological structures. Psycho means our psychological components in terms of our beliefs, our awareness of back pain, our psychological and other psychological factors. And lastly, social, that means some social factors that determine how likely we're going to get better or get worse based on our back pain. Things like our access to care, our ability to, our ability to cope based on our support systems, whether we have family members that can help us to deal with back pain, and a whole bunch of other factors that are considered social determinants of health. And the cost associated with low back pain is actually very high, especially in places like Canada and United States. In order to treat low back pain, there is just a lot of burden on our healthcare system. Even though we know these conditions are not that pathological or serious, however, it's just the fact that a lot of people are suffering from low back pain, and thus a lot of doctors, chiropractors, physios, healthcare providers have to be working very hard to help people with a condition. And let's see if there's anything else I want to talk about. And of course, as my role as a chiropractor is not only to help to identify, diagnose, treat, manage, but also to educate on low back pain and the importance of us taking care of our body, our low back, and just our health in general. Anyhow, sorry for the long introduction. Now I'm going to get into my workout, and during my sets, I'll probably come back and talk a little bit more about some specific low back pain. Now, previously, when I first graduated from school, I used more of a biomechanical approach to low back pain, and now I realized that was sort of wrong, or it misses certain aspects of low back pain. So a lot of times I tell patients, okay, because you don't have enough range of motion, or because you don't have enough strength, you don't move properly, and you don't move frequently enough. While some of those may be or may have certain truth, however, those are actually pretty wrong for the most part. Oh, excuse me. So now as a chiropractor, I talk about some of the bigger picture, some lifestyle factors. So a lot of times your back pain may be due to the fact that you haven't been active, your lifestyle has been more sedentary due to your work, due to your responsibilities at home, possibly due to a bunch of different other reasons. Also, things I often talk about is focusing on proper recovery, sleep. Those are very important when we're dealing with any type of injury. Additionally, our nutrition, especially having a well-balanced diet that includes a good portion of fruits and veggies, a decent portion of protein, and another relatively good portion of carbohydrates. And that will help to nourish our body so our body can recover properly from these injuries. And the next part, of course, is the physical activities, regular exercises. I don't think I need to elaborate on that too much. It's just that the more we use our body will be more capable in terms of dealing with any stresses or strains that come from various sports, from our daily activities. And lastly is about stress management. Now, we're not just talking about the physical stress that we experience and how we manage that, but we're also talking about some mental and psychological stress, especially when we do have pain. If you're stressed psychologically, if you're dealing with various psychological issues, mental health conditions, that could impact on how we perceive the pain. Normally, maybe the pain will only be about 3 out of 10. Now, when you have some health conditions, comorbidities, or psychological stress, and especially when you're worried about that pain, your pain could be perceived as something like a 9 out of 10. So again, the 4 main big things are working on proper sleep, nutrition, getting adequate exercises, and managing your stress. Let's talk specifically about non-specific low back pain. Again, it's called non-specific low back pain, which is the 85 to 90% of all types of low back pain. The reason why it's called non-specific because we know it's not specifically a fracture, it's not specifically a type of cancer that's contributing to back pain, it's not infection, it's not something that's pathological. Hence, it's called non-specific low back pain. And that's something I diagnose with pretty much most of the patients that I see. Of course, I've seen some cases of rare inflammatory arthritis that's causing their back pain. However, they've already gone through a battery of examination, whether it's imaging, blood work, to sort of confirm those. So now, in terms of non-specific low back pain, even though it's non-specific, we can still be somewhat specific with our approach. As in, if somebody present with limited flexion when they come in, your treatment, at least initially, is going to be different than somebody who is limited in terms of extension or who's limited in side flexion or rotation. And of course, the exercises that we select at the beginning are going to be a little bit more specific to their presentation. However, the general theme or the general approach still will be very similar. Now, exercise is something that I emphasize personally as a chiropractor quite a bit because not only it helps to relieve back pain short-term and long-term, it also helps to promote self-efficacy and self-confidence. So as a patient, knowing that there's something that you can do at home rather than relying on your chiropractor or physio would, I think, be very beneficial for their own recovery and prognosis in general. Now, with non-specific low back pain, there are other ways of managing as well. So things potentially could be medication like NSAIDs, non-steroidal anti-inflammatories. That's something that I cannot recommend as a chiropractor. However, when you do speak to your pharmacist or a medical doctor, they may recommend those medications as research has shown to help with certain types of, especially acute low back pain. Again, I'm not making any recommendation on medication. I'm just saying that statistically speaking and based on research, certain medications have been shown to be helpful. Now, other interventions that I use as a chiropractor include spinal manipulative therapy or spinal manipulation, or we call it chiropractic adjustment. That's when we're cracking or popping the spine. Now, we're not breaking anything, nothing is being cracked. It's just the air that's being formed and released within our synovial joints in the lower back. So manipulation have been shown to help with low back pain. And the mechanism, well, there's a couple of different theories on the mechanism. So I won't elaborate too deep into that. However, manipulation does help with low back pain. And it's relatively low risk. However, there are still risks, just like anything else, like medication, exercises as well. However, overall, the risks are low, especially when we rule out any serious pathological conditions that could potentially contribute to low back pain. In addition to manipulation, exercise, one of the best things that I could do for my patient is actually giving patients advice and reassurance and education on their condition. A lot of times the fears that we have towards something is because we don't know much about it or we have some misunderstanding of this condition. The fear of unknown, for example. So when we understand how the body functions and what the low back pain is and how likely it's going to get better and what are the things that we can do to self-manage, then some of that fear, that worry will decrease, and thus you're likely to move your body more and not be so concerned about certain positions or exercises. Then you'll actually be productive in terms of managing your low back. So giving that advice, education, and reassurance is actually really helpful to many patients. And there's lots of clinical guidelines that recommend giving patient education, advice, reassurance as first line of therapy, along with a few other things. Anyhow, back to my exercise. My hands and my muscles, my forearms are failing before my back. It's about 52.5 pounds on each side, so just over 100, well, it's 105 pounds. So again, the grand scheme of things is not that heavy compared to some of the weight that we do when we're deadlifting or squatting. For those of you who don't know, I've been dealing with a bit of calf strain and also Achilles tendon irritation. So I've been just doing some heavy calf raises with a straight knee and bent knee to manage that and to sort of strengthen and hopefully create some adaptation to my tissues. And there's some research on heavy loading for tendinopathy. So don't be scared to load your body heavy. Just listen to your body, do what you can do so that you're not aggravating your symptoms at the same time trying to optimize your symptoms. Before I forget, let's talk a little bit about anatomy of the low back. So generally speaking, low back is considered anywhere from the lower portion of the last pair of ribs, which is around 4, 3, 2, 1. So your ribs are at the T12 level, that's where it ends. So from here all the way to the top of the iliac crest, this portion of your body is technically considered your low back. Now, of course, when we're dealing with low back pain, a lot of times we do get some pelvic pain, hip pain, and even lower in the sacral and coccyx area. So these, I would still consider them low back pain as well. So in terms of specific anatomy, the last 5 vertebrae before your sacrum, so 5, 4, 3, 2, 1. These are considered your lumbar spine. So the anatomy, the shape, the orientation of the joints are going to be different than the 12 thoracic spine that we have in this area, which are going to be different than the first 7 cervical spine. And in terms of specific joints in our lumbar spine or throughout the entire spine, we have these structures called the intervertebral discs. So they're considered soft tissue. I could consider them as soft tissue, connective tissue structures. So they allow motion, movement at our spine. And the white part, this is a vertebral body. So they help to absorb pressure. Actually, the vertebral body has ability to give, actually, based on the formation of the matrices in the vertebral body. So a lot of times we think the discs are the shock absorbers, but in reality, the bones are actually the shock absorbers of our spine. Now with the disc, with the vertebral body, when we come back here, we have these articulations. They're called the facet joint or zygoapophyseal joints. So these are the joints that actually create that popping noise, because as we manipulate or adjust the spine, we gap these joints. Oops, that's dislocating. We're not doing that. We're gapping these joints. So by gapping that joint, creating a negative pressure within the synovial fluid of that joint, a bubble is formed, and then that bubble bursts. So that process, we used to call it cavitation. However, now we know it's actually not. It's called tribonucleation, which is the forming and the popping of the gas bubble. Cavitation is more so just the popping of the gas bubble. So based on physics, there are slight differences. Now, with these facet joints, sometimes they could get irritated, that's causing pain or discomfort. So for example, again, this is a simple explanation. There are a lot of nuances to this. If we go into extension or rotation in that position, we could potentially jam or irritate the facet joint. They're never bone on bone. However, when they're irritated, when there's already fluid within that area or soft tissue swelling, when we approximate that joint by moving the joints close together, there could be a higher chance of irritation. Now, in terms of low back, these yellow structures, these are called the nerve roots. So they're extensions of your spinal cord that comes all the way from your brainstem down to about L2, 3 level of your spine. And then the spinal cords, they essentially go down to your bum, into your legs, to put the rest of your extremities to innervate them. so that you could feel things in your lower extremity. You can use and control your muscles in your lower extremities, and they serve a whole bunch of purposes. Think of these more like the electrical wires of our house, and the brain sort of the central control system or the computer, and then your muscles and joints are kind of like the individual parts that gets controlled by the electricity that move. I don't know if that's the best analogy. And then lastly, down to this part, this is the ilium, which part of your pelvis, and then sacrum, still part of your spine. That joint is called the sacroiliac joint. It's one of the largest joints in our body. This sacroiliac joint could potentially get irritated and lead to low back pain as well, and that's something that we treat often. Again, there's a lot of misconception about the function, or how do I say it, about the SI joint, because a lot of people say, okay, the SI joint is stuck, we need to manipulate them so that we can unstuck it. However, based on what we know, the SI joint actually moves only about anywhere between 1 to 3 millimeter. So the motion at that joint is fairly minimal. So we can't say that because the joint is stuck, that's how we get low back pain. And also when we mobilize the low back, when we press on the PSIS, the posterior superior iliac spine, we feel that tension. Again, we cannot definitively say that's because that SI joint that's stuck or that's restricted. It's likely a combination of tightness or spasm of the muscles around the area, or that's just your normal anatomy. And what else do I need to explain? And of course, if you have some hip problem, the ball and socket joint issues, that could refer into the lower back area and potentially make us think it's low back pain. So, and vice versa, the low back could refer into the hip. So sometimes it is tough to diagnose where exactly the pain is coming from. However, we do know, generally speaking, movement, whether it's at your lower back, or your pelvis, or at your hip, they're all very important in terms of dealing with low back or pain in general. Other than that, let's see. Let's talk a little bit more about the discs, because they actually been, I guess, a hot topic for various reasons. Before, or a lot of people like to use the analogy that discs are like jelly-filled donuts. Once you put pressure, the inner jelly gets squished out and pushed onto your nerve. That is absolutely not true, at least not to that extent. Of course, the outer layer of the disc, they're mostly fibrous. That's the annular fibrosis. So they are very, very strong, and they kind of have different orientations, kind of like, what's the word I'm looking for? So one layer is oriented this way, the other layer orients that way. So they are very, very resilient to pressure. And oftentimes, when we do have a disc herniation or a disc bulge, that's the area that potentially gets weakened due to various factors. It could be certain movement, however, it could be due to genetics, your lifestyle, and a whole bunch of other things that we may not know. So, and the inner material that gets protruded or that gets squished out, that's the nucleus pulposus, which is a little bit more like jelly, but not quite. It's this viscous, mostly water-based material. So when we're younger, we're at higher risk of developing a disc herniation because our discs are just more well hydrated. As we get older into our 50s, 60s, what happens is that the discs, they actually start to dry out. So it's less likely to get a disc herniation. However, there's higher chance to have disc bulges, which are now, we know, are common aging-related changes. So they, again, may not necessarily explain our low back pain. So for example, when we x-ray somebody who's over the age of, let's say, 65, random 10 people within that age category, to x-ray all of them, probably 8, 9, or even 10 out of 10 would have disc bulges or degenerative disc disease or degenerative joint disease, which are thinning of the disc and potentially bone spurs. However, out of those 10 people or 8 or 9 people that do have these findings, probably 2 or 3, again, don't quote me on the specific stats, probably a lower proportion of them actually experience low back pain in any given moment. So again, for those people who do have symptoms of back pain and do have those degenerative or aging related changes, they probably had those changes before their current episode of low back pain. Those changes probably been there for the last 5 years or possibly in 10 years. So again, all of a sudden when they have back pain, we cannot just say, oh, it's because of these arthritic changes. The arthritic changes were there to begin with. So your symptom all of a sudden changed or all of a sudden became present. We cannot explain that based on something that was already there for many years to come. So that's why using the pure biomechanical model is not the most comprehensive way to explain things. Anyhow, I think I went on too long. Better get back to my training. Also, I apologize. I'm not the most articulate person, and that's probably part of the reason why I'm trying to create these YouTube videos so that I can work on my speaking skills, my communication skills. So again, if I misquote, use things like or pause for an extended period of time, I apologize. I'm gonna keep working on my communication skills. Hopefully I could be a better communicator and more effective communicator in the future. It's a little heavy for my shoulder. Let's just do some. too easy. The load is too light. This is probably better. Maybe too much. Internal rotation is pretty lousy. By the way, I'm a tennis player, so I do a lot of overhead activities. And it's a common theme to see that tennis players do have excess external rotation. However, internal rotation are slightly limited. And that's not necessarily a problem. That's more so an adaptation to our sport. And this is more also commonly seen in volleyball players, badminton players, because the overhead nature of our swings. Okay, let's talk a little bit about exercise selection for low back pain. Now, we often like to find the best exercise for the back. You know, online you see things like bird dog, dead bugs, side planks, curl ups. Some people say deadlifts, squats. Some people say you have to do crunches or Supermans. Again, what's the truth? What does the scientific evidence say? So generally speaking, there's no best exercise. And at the same time, there's no worst exercise. And also generally speaking, the best exercise for your low back pain is the one that you're going to stick to, that you're going to adhere to. And the worst exercise is the one that you're not doing, because you're not doing that exercise. So how can you gain any benefit out of it? So again, compared to when I was in school, to earlier portion of my career, to now, my view on this topic of exercise selection has changed. Because in school, we emphasize on the McGill Big Three, which consists of side planks, modified curl up, and bird dogs. These are the three exercises that have been shown in research to promote spinal stability. And the premise behind that is that when we have spinal instability, there is a higher risk for low back pain. However, we know that's not completely true. So assuming that was true, then of course, if we work on our spinal stability, the ability to stay stable, resist movement, then of course that would improve our low back pain. And oftentimes, when I give patient these three exercises, especially in the past, people do feel better because these are relatively safe or really safe exercises. Most likely they will not aggravate somebody's low back pain. So the McGill Big Three consists of curl ups, modified curl ups, bird dogs, and side planks. I used to give these exercises more regularly. And let's say over the last 3 years, I probably have not given these exercises due to a whole bunch of factors. And now later, I learned that with low back pain, we just want to gradually and progressively load the tissues so that we can get accustomed to those positions and loads and pressure, so our body can slowly adapt. And as we adapt and improve, we can apply more load and we're going to improve even further. So that is called graded exposure or progressive overload. And that's a common or a really important principle to follow when it comes to strength and conditioning, or just anything in life. If we're not good at something, if we're fearful of something, we gradually expose that and we gradually increase the exposure, then chances are we're going to be good at doing that, or our fear of that will be lessened. And nowadays, especially as of late, and based on my additional training, additional courses that I took, I realized that the spinal stability exercises are great. However, we also want to work on variability and mobility. So how much range we have in our lower back and how much control we have over that range. So earlier you saw me doing Jefferson curl, where I was holding weights and curling, rounding my upper back, neck, and then to my lower back and coming back up slowly with control. That's one of the exercises. Again, I'm not saying that's the best exercise for low back pain. However, that's one of the exercises that promote control and mobility of my spine. And you saw that I used over 100 pounds for that, and that is not inherent, that exercise or flexion is not inherently bad for my spine, the discs or the joints, especially when I've worked up my way to that. And I'm seeing online on the internet where there are people that are lifting like 200, 300 pounds doing exercise like that. So again, they didn't go from not doing that exercise to all of a sudden doing that exercise at that weight. They probably gradually built up the intensity of or the weight of those exercises. So again, don't worry about spinal flexion or in terms of rehabbing your low back, because it is not a risk factor for low back pain. On the flip side, of course, when we have a new acute low back pain and when you present with limited ability to flex, of course, initially we do not want to, well, depends on how you look at it. Initially, we'll probably do not want to get the patient to go into flexion too much with too much load, especially because that's already some position that are sensitive. So instead, we want to just focus on some movement that they can do. If they can go into extension without much discomfort, or side flexion or rotation, then get the patient to do those exercises. Later, when the pain and the symptoms have calmed down, then I believe we should work on flexion, because the longer we avoid working on something that we're not good at, the longer we will, well, the likelihood that we will not be able to have the full function in that position will be increased. If you don't use it, you lose it. So again, to summarize, generally avoid things that trigger your discomfort initially, and then get back into doing those things that used to trigger your discomfort and help to improve that. Let's see what else I want to talk about in terms of exercise and exercise selection. Again, in order to find the best exercise for you, you want to probably try a combination of different exercises and see which ones you feel comfortable with. Stick to those at the beginning, and then later find some other ones that also could be productive for your back pain, especially if you have certain limitations, and those exercises will be the right exercise to work on those specific limitations. So what else did you see me do? I did some squats, I did some camels, which are great starting points. I did the power press with the orange band over there, because initially that black band was just, the load was just too little. So it's not going to give me any major therapeutic benefits, versus with the orange band, it's a lot tougher. So that really helps me to engage some of the muscles in my body. So again, that load also plays a role. If you do a lot of just purely body weight or light load exercises, they might not be enough to elicit a adaptation or physiological benefit. So even though they might not be harmful, they might just not be that useful. But again, if you're not doing any exercises, then I think any exercise would likely help. And let's say if you perform an exercise, it consistently create or lead to sharp pain, high intensity of pain, or new pain that you're not used to experiencing, then those are the moments where we need to take a pause or just stop and sort of reassess why that's the reason, and perhaps that exercise at this given time is not the right exercise for you per se. And once your symptoms calm down, perhaps we can try going back to those exercises if you want to try doing those exercises. And again, a whole bunch of other exercises like deadlift, good mornings, planks, let's see what else, bent over rows. Those are all good options to help you deal with your low back pain. So again, the fundamental message is that there's no bad or good exercise. The exercise that you're doing is the one that will be best or most effective or helpful to you. And the ones that you're not doing are not going to help you in any way, shape, or form. So have some exercises or a few that you enjoy to do. And as you work on that consistently, you'll likely, hopefully, experience recover from your lower back pain quicker. Oh, the other thing I want to talk about is the natural history of low back pain. Again, just like any condition, many conditions are self-limiting, as in if you don't do any treatment, just give it enough time, the condition will get better and improve. And that's not to say that you don't need to do anything, you just sit around all day and wait for it to get better. It just means that you don't necessarily need any specific intervention, like seeing a chiropractor or going to physio or taking medications. For low back pain, the natural history, again, depending on what you read, depending on what type of low back pain, if you have an acute flare-up of low back pain that has any red flags, yellow flags, and you've never experienced low back pain in the past and you're fairly healthy, a chance of recovering from that acute episode within the first, let's say, 3 weeks is pretty high. Of course, there are a whole bunch of other factors that influence this. If you have a lot of health issues, multiple medications, history of low back pain, this seems to be something that's chronic and recurrent, your likelihood of getting significant improvement is going to decrease, and the chance of you recovering would probably take a little bit longer. Anyhow, I'll come back. Again, I used to do a lot more of these exercises. Now, not so much, because even when you're doing things like Jefferson curl or quote unquote mobility exercises, you're still tensioning your muscles for control. So of course, there will still be stability with your spine when you're doing those exercises. So when these exercises that commonly are deemed stability exercises, again, you may not necessarily need to do them. I just do these because I find them pretty challenging and it helps a little bit. But they're not the end all be all to rehabbing your low back. Again, just like eating a nutritious, balanced diet, you want diversity, you want variability. That's why I tend to do a bunch of different things when I work out, just so that your body is exposed to various things. And if you find something that's really productive to help with their specific issues, whether it's your low back pain, whether it's your performance in a sport, then you just try to do that a little bit more. Anyhow, I don't think I was working very hard. I probably just hardly working during that workout. And I did talk a lot and pause a lot from my workout. Anyhow, I hope that this video was informative and comprehensive and answered some of your misconceptions or some of the questions you may have. And if you do have any further questions, specific questions, please feel free to send me a DM via Instagram at Dr. Jason Xue. No space, DRJASONXUE, and I'll be more than happy to answer your questions. And if you're somebody who is interested in coming to see me for a virtual appointment or an appointment in person, if you're here in Toronto, feel free to reach out as well, and we can set something up either virtually or in person at any of the 3 clinics that I work at. Anyhow, peace.